So, in the world of transplantation, the whole process involves making multiple complex decisions. And we know in order to make good decisions, we need good evidence and it needs to be well communicated. Currently, we're not very good at communicating information. When we look at the readability scoring systems from materials on chronic kidney disease from the UK, the US, and Australia, the patient information materials aimed at patients with chronic kidney disease are based at patients with an average literacy level. So in the dark grey, you can see the number of materials that are targeted to patients with an average literacy level, and these are the number of materials targeted at patients with a low literacy level. So you can see that with the written information we're giving out, we're not very good at communicating at the minute. And the current NHS guidelines suggest that for all the information we're giving out, we should target this at a literacy level of around 10 years old. And we have no idea what numeracy level we should be targeting. So firstly, what is NHS Blood and Transplant? Essentially, it's a special health authority which is responsible for the supply of blood, organs and tissues in the UK. This slide is a little bit old now, but in the UK last year, but this remains true, that last year there were just over 6,000 patients active on the organ transplant waiting list. And even though you can see that the number of organ transplants performed are increasing year on year, organ shortage remains a major issue, and there are people dying on the waiting list every year. In the UK Transplant Registry held by NHS Blood and Transplant collects data on all potential recipients of organ transplants from the time of entering the waiting list, all offers made to these recipients, all transplant conducted, and the outcome data. So we've got a pretty good database. It's mandated to go through that database. So we've got data on all transplants that occur. There's a dedicated statistics and clinical studies team, and they work all year round to keep this database in shape and regularly produce annual and monthly reports, which clinicians use to help make decisions with their patients, and patients can also read. It's all nationally available, and local outcomes are also published in these reports. So these reports provide crucial information to transplant centres and inform policies, and they have a direct impact on clinical decision making. Despite that, there is lots of improvement that can be made in the way that we communicate this information on transplants with patients. So in the real world setting, the transplantation is made up of many stories and experiences from countless individuals, but I'll just give you an idea of what the process might look like for a patient for a potential kidney transplant recipient. So I have to say, for all this talk, I'm interested in kidney transplants, so it might be a little bit biased. So the first bit of the transplantation process is that you need to be ready to be listed for transplantation. After that, your name is entered onto the database, and every time an organ comes up, you will be offered, and you may or may not be offered an organ, depending on the organ offering scheme. At that point, you can choose whether to accept or decline the organ. You'll proceed for your transplantation if you accept the organ, and then you have your post-transplant care, and later on maybe death. Although we know that these things don't necessarily occur in this order. And with this comes many questions that the patients might ask us. So firstly, should I be listed for kidney transplantation? What is my expected survival, and how long do I need to wait for an organ? What might happen if I get removed from the list? And when the organ offer comes, which the major tricky question is, should I accept this organ? If I say no, how much longer will I wait? And what is the survival benefit of me taking a lower quality organ now versus waiting for a higher quality organ? Then, what is my post-transplant survival? So the questions in the green box are things that we can possibly answer using the data that we've got, or help give an idea of with patients with similar characteristics to the patient asking us the question. The questions in the purple box are questions that we're not quite sure how to answer with the data that we've got yet. So in the UK, organs are offered to patients in different ways. So for heart and lungs, organs are offered to centres, and then they are then and they're then offered to patients based on what the clinicians feel. For livers, pancreases, kidneys, and intestines, the offers are made to named patients. So just to give an idea of why the offering scheme is important and the role statistics play with this. So if we take the liver, we can see that this is the transplant benefit score. So the new liver allocation scheme, which was introduced to the UK in 2018, was purely based on UK Transplant Registry Data. And the idea is to match a deceased donor who with their livers to patients on the liver transplant waiting list in an objective way. This has a huge burden of responsibility on this scheme to ensure that the right liver is offered to the right patient in a timely manner. So the scheme was developed taking into account 7 donor characteristics and 21 transplant characteristics, and used a method of sequential analysis to generate a transplant benefit score. The transplant benefit score was calculated for each patient on the list by measuring the difference between the area under the predicted waiting list survival curve and the area under the predicted post-transplant survival curve over a 5-year interval. And this approach was used to develop the transplant benefit scoring system. So you can see how important statistics are, because the whole offering scheme was developed on this. And for each organ, there is a separate organ offering scheme and a separate methodology to inform it. So if we go back, what patients want to know at the time in kidney transplant, one of the main things that happen is when the organ is offered to them, because we've taken the burden of the offering scheme, but for the patient, what they want to know is, should I accept this organ? And if not, how much longer will I wait? And if we look at reliable resources such as the Daily Mail online, we can see that there is many different aspects to this. So for example, these are just some I typed in transplant and this is what came up. So there was a heartbroken transplant patient who was given a kidney from a 25 a day smoker and is on a lifetime of dialysis after it just failed. Then there was this horrible case where kidney transplants recipients were infected with a parasitic worm. And there was another patient who suffered from, just 19 years old, who suffered from the consequences of organ transplantation. On the other hand, you've got these heartwarming stories, which are, for example, patients who find life on the waiting list absolute hell, and also these medical breakthroughs. So, for example, giving transplants to patients who are HIV positive, which are obviously life-saving for these patients. So it's just to show that each patient's story is really different. So even though we've got the statistics to inform what might happen, there's patients who think life on the waiting list is hell, and there are patients who suffer with kidney transplants. So one of the main things that we need to do is to communicate risk, and that involves an element of risk literacy. So this is one of my favorite studies from a German psychologist called Gerd Gigerenzer, who you may be familiar with. And he asked people in 5 metropolitan cities what it meant by there is a 30% chance of rain tomorrow. So this is something that we hear all the time on the news. We know exactly what it means, right? 30% chance of rain tomorrow. But these people responded, these are people on the street, average people, it will rain tomorrow 30% of the time. It will rain tomorrow in 30% of the region. It will rain tomorrow on 30% of the days for which this prediction has been made, or 30% of weather forecasters think it will rain tomorrow. So there is a huge discrepancy in what we are saying and what is being interpreted, even with these simple comments. So saying something like you have a 90% chance of post-transplant survival adds in complexities. And one of the main things that Gerd Gigerenzer teaches is that people should be taught numeracy in school as well as literacy, and that is equally as important. And also the way we portray risk is extremely important. So Alex Freeman is a communication expert, and she gave me this example, which is from a study, which is what represents the biggest risk: 1 in 100, 1 in 1,000, or 1 in 10. And they asked university students this question, and the percentage with an incorrect answer in the USA, it was 25%. And if you think, oh well, that was in America. In Germany, it was 28%. So what we're saying, this is an example of denominator neglect. So changing a denominator confuses people. Numbers do not speak for themselves. We give them meaning, and that's one of the favorite quotes from I think it's Nate Silver, and that's one of the main things I learned from all the risk communication research that I was doing. So, in the world of transplantation, what do we have to help us when we're communicating risk? We have consent guidelines, we have local booklets and videos, and these are in a variety of languages and really helpful. We have written and verbal consent, which is variable between clinician to clinician, and we also have online resources. The US have some amazing online resources and calculators, such as these animated videos, but in the UK, the experience is slightly different, even though we have just as good a database. So we wanted to develop a risk communication tool and the idea behind this tool is that it should identify areas of communication need, it should be easy to use, it should be statistically sound, of course, and it should just be a communication aid. So we've understood from all these nuances that I've described that you can't base your decision just based on data alone because everyone's experience is totally different. But if we can communicate the risks, it would help people make better decisions. So one of the models that we tried to develop was an outcome from listening models. So from the time of transplantation, the patient can get transplanted, they can die, or they can get removed from the list. And these outcomes are competing risks, which means that one event occurring precludes another event from occurring. So, for example, if you die, you cannot get transplanted. If you get removed from the list, you cannot get transplanted at this point. So, in the world of medical research, when there's only one type of outcome, commonly Cox proportional hazard regression modeling is used in medical research, and so all-cause mortality. And this model allows one to estimate the association of variables with the rate at which events can occur. But when competing risks are present, we must use different methodologies, which I'm sure you might be familiar with. So we wanted to use a competing risk methodology to help demonstrate individualized patient outcomes from the time of listing from deceased donor kidney transplantation and clinically apply this into a patient communication tool. So for someone that's not a statistician, I found this paper really interesting to help understand what a competing risk model was. And this might be sort of too basic, but for me, it really helped. So that in survival analyses, all people who are at risk of experiencing an event are considered part of a risk set. And at each point in time, the risk set consists of persons who have not experienced the event of interest during follow-up prior to the specific time point. So in this case, this is the risk set. However, you can see that the people being taken out are the people who have died and the people that have experienced the competing event. And that will give you a cause-specific hazard. In a competing risk analysis, only patients who have the event of interest are taken out of the equation, and that gives you a totally different hazard, and that gives you a sub-distribution hazard ratio. And that is my very simple way of understanding what the basis of a competing risk analysis is. And if you look at the results of this, if this is, for example, for lung transplantation, if you model the competing risks, you can see that the chances of getting transplanted, dying, and removed from the list can be demonstrated in this sort of way. And what a patient communication tool might look like. So you can add in all these patient characteristics, and this is the outcome you might get. So if a patient who is 50 to 59 years old on the kidney transplant waiting list, these are their chances of transplantation, removal, and death. And if you get a patient who's then 70 plus, so obviously this was 50 to 59 years old, this is a patient who's 70 plus, the chances of being transplanted become less, the chances of being removed increase, and the chances of dying increase. But to a patient, that might all still be nonsense. There's no point if the patient can't understand what we're trying to communicate. So what we tried to do together with the Winton Centre was to develop a tool which was easily interpretable. So essentially what we did was to was to develop a tool which demonstrated the same outcomes but in different ways. So we put the same numbers in as a bar chart, as an area chart, as icon arrays, as tables, and as text. So patients can see so patients can see the answers to their questions in a format which is interpretable to them. So you can see, for example, if we're looking at post-transplant survival, this is the percentage of failed transplants after a year, after 3 years, after 5 years, and these are the percentage of kidneys that are still working. And that same data is provided as icon arrays, so people can help understand what they're doing, and this can be printed out and given to patients, so they can interpret this with their families at home and then help make decisions. So, to conclude, I hope I've demonstrated that transplantation and statistics go hand in hand. With the modelling, there was a lot of trial and error, particularly with the competing risk modelling. And we need to focus on what patients need and what they want. There's no point trying to demonstrate things which they don't want. And we need clear and easily interpretable statistics. Thank you very much for your time.
Thank you very much, Maria. That was great. So if anyone has any questions back home, throw them in the chat, and I'm sure we can read them out. Are there any particular questions in the room, or do you need time to think? Because I have 3 totally written down here. Any questions from the room? Go for it. I'll kind of reiterate unless you want to come up.
Okay, well, thank you very much. Point 1. So what input do patients have to this sort of developing of these tools?
So in case you didn't hear that, the question was, what input did patients have in the development of the tool?
Thank you. So they had a huge impact, but actually there was a disconnect between what we could provide and what patients wanted to know, and it was just about trying to bridge that gap. So one of the one employee from the Winton Centre, their full-time job was to go to different transplant centres and find out how we were taking consent at the moment, how are we communicating risk, and what do patients want to know. Unfortunately, that didn't always correlate with what we were able to provide with the data, and that was always an issue of trying to bridge the gap, but we're trying to develop models which were statistically sound. So, for example, when we looked at post-transplant outcomes, we did it up to 5-year survival, but patients wanted to know the longer survival because transplants lasting a lot longer. But we used a Cox proportional hazard model, and the assumptions of proportionality were not met if you increase the time. And secondly, you have to go back further into the data. So you're taking transplants that occurred that bit longer ago, 5 years prior to that. So the outcomes are not as good as providing more recent data. So it was a real struggle to balance what patients wanted without producing bad data.
Comments on that? Or? One quick question I have is, you said about the different organs are allocated in different ways. You said heart and lung, I believe, were given to the centre and then they decide what's going on, and the rest of them is more of a patient decision. What's the rationale underlying that decision to have the system in that way?
Yeah, so heart and lungs, you need to transplant them really quickly. So you need to get them to the nearest centre as quickly as possible. And because the numbers are much smaller than with kidneys, lungs, intestines are quite small as well, actually. Because the numbers are much smaller, the clinicians often have a good overview of who is the priority at that moment in time. So that's why they're still allocated as super urgent, and national. So there is still a tiering system, but it's centre based.
Cool, thank you. Any other questions from the room? I'm going to take this opportunity again then. You mentioned in the beginning, basically I have this kind of question written down here about what's the bigger problem? Is it that do we not have the right information, or do we not understand the information we have? The whole 30% chance of rain stuff. And this tool is developed and it gives everything in percentages as the output. So how have the patients taken to that, and are they okay with the percentages, and are we okay giving them percentages when we just mentioned how maybe people don't get percentages?
Yeah, so I don't know if I didn't really demonstrate it well, because my go-to was obviously to demonstrate the bar chart again. But if you go across, there's sort of the icon arrays, and then it's written in text. So the text, instead of giving a percentage, it will be like 9 of 100 people will, and so it's sort of the same numbers are put in as many ways as we could think of to give to suit whatever could be interpreted by that person. So it's not all percentages. So the icon arrays are the little emojis or the little faces should help with that problem. Also text. Also, some people do like percentages. Also the graphics, just portraying it in a number of different ways and sitting down and really explaining to people that this is what that means.
Yeah, it's like taking that multifaceted approach, or the multiple directions they can actually like hone in on what the true
and like just understanding one size doesn't fit all. Like survival curves are not interpretable to people who've never seen them before. In fact, even to people who've seen them before, they take it at face value and they don't understand that there's a range of error and uncertainty, which was another challenge to try and portray, which we haven't really got over yet. I'm still trying to work on it.
Good. We have a question we'll take from the back and then we'll go to the front.
What do you do when a patient lacks capacity and the next of kin also lacks capacity? The principle of medical ethics and beneficence. And
so what I heard was, what do you do if a patient lacks capacity and their next of kin also lacks capacity? Is that right? So what we do is we get an independent advocate in that case, and we set up something called an IMCA, because we might have our own agendas as doctors, and that's something to be important. That's something to be aware of. So I don't think it's something that the medical team alone can advise. So not just for transplantation, but in all aspects of medicine. If we're going down that route, then we get external advice and external input. So they have an IMCA. Firstly, you have to assess, do they truly lack capacity? Because you can lack capacity for one thing in your life, but you can have capacity for another. So, for example, you can have capacity to decide what to have for breakfast this morning, but you might not have a capacity to decide should you have a transplant or not. You need to decide that for the question that you're asking, do you have capacity? Does the patient have capacity or not? Secondly, even if the next of kin did have capacity, it's not necessarily the correct thing to do to burden the next of kin with that responsibility, and it's not always legally allowed unless they have a lasting power of attorney. And so you often get independent parties involved.
Any comeback on that, or is that okay? No.
This is a common thing that we encounter in the NHS, where patients aren't able to decide for themselves. And it's a very difficult scenario.
Yeah. So the comment from the room is that it is a very difficult scenario to actually balance this and trying to find out what the morally correct thing to do is. Should we go left to right then first?
But the other thing to remember with that, sorry, I just wanted to remind you. So even with
had a potentially fatal illness, and I was told I had a 70% chance of survival. But at the end of the day, you either live or you die. And how do you communicate that? That's the really difficult thing, I think. Not the actual level of the risk. People want to know whether they're going to live or die. That's the
yeah, they do, and we can only help. But I just think that rather than the reports that we've got, which are 180 pages long and contain a lot of information, these kind of tools can just help portray that to people. But it's also understanding that for you, a 70% of survival might not have seemed like a very good thing. But for other patients who have had a lot of medical interventions, have a lot of morbidity, so illnesses going on, and are basically at death's door anyway, 70% chance of survival might be pretty good for them. So So that will mean different things to different people.
Deborah, do you want to go?
Yes. So firstly, thank you. That was a fascinating talk. I'm picking up really on your response to Simon's question about did you do sort of PPI patients, finding out what patients want? And I'm fascinated, but not at all surprised, that there's a mismatch between what patients want to know and the data and analyses you've got available. I'm curious as to whether some of the things they want to know are amenable to having data collected to come up with some answers, or whether they're different in kind and that's not possible. I mean, there's a separate question of whether it's worth the money and time and resources to collect that, and whether it would help their decision making. I'd just be interested in a little bit more about what came out of that piece of work. I'm so glad you did it, because that's a vital.
Yeah, I think what became very apparent is that there's a bit of both. So there's some things that we're just not going to be able to answer, like, for example, should I accept this kidney or not? Point blank. I mean, I can't make that decision for you. However, there are some things that we probably could answer if we had more time, money, resources, better data collection. So what we did in tandem with this tool is we developed a patient communication website. And on that website, it's got everything that we thought a patient would want to know, or from all the feedback that we got. So for example, how long am I going to stay in hospital for? Am I going to have a urinary catheter? What is a urinary catheter? You know, these sorts of things that will make a practical difference to them that they want to know, as well as, you know, how long might my graft survive, as well as that. What's important to them is how quickly can I drive again? How much time am I going to take off work? All those sorts of questions. So there's a more sort of qualitative approach. We've developed a national sort of information website in tandem with this, because it became apparent you cannot have these tools in isolation. It just doesn't work. I hope that answered it slightly. But yes, I hope we can develop them better.
Some kind of questions which are all almost, from what you're saying, the short-term pragmatic stuff, as opposed to the longer-term risk calculations.
I didn't quite catch.
I think Marie didn't hear Deborah's thought.
Oh, sorry. Do you want to repeat that again? Sorry.
Yes, it was just a comment that it's interesting that patients are concerned about some of the really practical stuff, some of which is data-based and some of which actually is just rather factual, rather than necessarily being focused on the longer term sort of risks and times of experience.
Yeah.
Definitely people more interested in day to day. Susanna.
Yeah, so I actually did have, it's not really a question, but there's a paper that I came across in a climate change context, which actually does a lot of discussion about different ways of discussing risk, if it's dragons of inaction. And it's just a really lovely paper, and I'd like to tell people that.
Could you share it on the chat online, if that's okay?
Sorry, could you repeat that again, Maria? We accidentally muted you. Well, I accidentally muted you.
I was just saying, if you could put the paper on the chat or a link to it, that would be great.
So are there any final questions? Because if there aren't any final questions, then it's left to me to say, Maria, thank you very, very much. We'll give you another round of applause. Thank you.
Thank you.
So we'll take a few minutes to get Deborah set up as our next speaker. So again, people at home, stretch your legs. People in the room, maybe stretch your legs as well. And we'll reconvene in, well, let's say more than 5 minutes. Let's say at least 7 minutes time. We'll reconvene around 10 past for the next speaker.
My comments for posterity about you really should join in and contribute haven't been recorded, but I think people who need to hear them heard them. So your theme today is medical decision making, and that got me thinking, because in many ways I've been involved in decision making in medicine my entire career, but I've also been involved over some decades in decision making in a very particular way, and that's actually sitting on data monitoring committees. And I've been having some thoughts, partly prompted by a new data monitoring committee I've been asked to sit on, in fact more than one, and I just thought this is a chance for me to sort of think through some ideas. So this isn't in the form of sort of completed work, but it's just partly some reflections on some trials I've been involved in, including some recent ones, and just trying to get my thoughts straight for the more complex world in which we now live. But it does involve some genuine decision making, which mostly as statisticians we kind of avoid because we give the data and some advice and it's other people's job. But when it comes to data monitoring committees, we really are the ones who have to.
It's the keyboard, so not the laptop.
It's right, so it's this keyboard.
Yeah. Click on the mouse, click on the screen.
Oh, this one?
Yeah. And then click again. Oh.
Brilliant. So I'm conscious that some members of this audience have lived and breathed clinical trials in some cases for even longer than I have, and others of you may only have the most superficial idea of what they are. So I thought I'd start at the beginning. And when it comes to comparing, it might be two treatments, it might be, as we'll come on to, two strategies for preventing a disease, it might be two screening policies. There's all sorts of ways of doing that comparison, but many people would refer to the gold standard as being a clinical trial. And that is seen as a rigorous, usually randomized test of the efficacy, which means does it work, and the safety of a new treatment compared either to the standard treatment, or it might be comparing two alternative strategies. Perhaps one's more expensive and one's cheaper, and you want to see if the cheaper one is at least nearly as good. And I would say that complements other forms of evidence, but for today's purposes, I want to focus on the clinical trial. Now, experimentation is not a new concept. It happens in non-health areas as well. And if you were doing field experiments, going back to the days of Rothamsted, you design your experiments, you divvy up your plots, you put your weed on, you put your seeds on, you put your fertilizers on, and then you sit back and go and do something else, probably read the biometrics journal or whatever, and then collect the data some months later. If you're dealing with experiments on animals, for example, you've got them all together, you can do them all at once. It might be psychological experiments on rats, it doesn't have to be anything too terrible, but again, you've got them all, and so you get into experiments. Patients aren't like that. The thing that distinguishes experiments in humans to most other forms of experiments is that they are not all sitting there just waiting for the trialist to come along and say, right, line up here, you know, people randomized to that door, the others through that door. They tend to come to clinics or wherever a few at a time. And what that means is that we recruit the patients and start following up so that information on some patients is starting to emerge often before later patients are recruited at all. If you've ever been involved in a trial where the recruitment is poor, you will really know that. And so the ethical issue that starts to emerge is if the data all start to tip in one direction, either showing this is a really good treatment, or as some trials I've been involved in, showing that the treatment isn't as good as we'd hoped, at what point do you pull the plug and either say, right, we know what treatment we should be using, or to say, right, let's bin that and do something different. And there's clearly risk and benefit. If you carry on too long, you may be giving a harmful treatment to too many people. But if you stop too soon, you may be convinced, oh, it's hit the magic peak was 0.05, but that may not be enough to convince other people. And then you're in this mess where the treatment doesn't actually get adopted because a lot of people don't believe you. So there's this trade-off between the patients in the trial and the reason you do the trial in the first place, which is to get convincing evidence. And of course, as statisticians, we know the more you test, the more random things happen, and treatment can look good or bad just by chance. So that has been a dilemma, been there for some while. And the convention is that a group that are called a data monitoring committee, there may be similar and slight variations on that, but is asked typically to review the data in confidence as it emerges and to advise if they believe that recruitment should be stopped or modified. And it's in confidence because the whole point is that there's an idea of equipoise, that people entering patients into the trial shouldn't have beliefs about one treatment being better than another. If they do, they shouldn't be clinically entering those patients. And yet they can be unduly influenced by really quite dodgy data. So the Data Monitoring Committee are a group of wise, appropriately constituted people who review in confidence. And that's one of the reasons that there's layers of decision making involved in clinical trials, and clinical trials then inform other people's decision making. But the data monitoring committee, if it advises, technically someone else makes that decision, but it can stop a trial in its tracks with all the consequence of that, or it can afterwards be asked, well, why didn't you call it earlier? Because you've done some harm, or you've stopped this beneficial treatment getting out there as soon as you should. So that's the world we're in. Now, if any of you have done a course in medical statistics with clinical trials, the chances are that you might have come across data monitoring, and it will almost certainly, at least initially, have been for 2 group trials. The classic group sequential tests were initially often frequentists and started off just being sequential with the idea that you analysed after every patient, rather like analogous to what you might do in industry of looking after every item that you'd inspected. But actually, of course, in practice with data flows, you tend to analyse might be every 50 patients or every 100 patients. And so procedures have been developed, and I'm not going to give the statistics of this, some of you know it and others of you could work it out from first principles, but the idea is that if you're going to look, for example, at 5 times during the trial, you adjust those p-values so you preserve your overall 5% if that's what you want to do. And there's names like Ibrahim Fleming, there's a Peto rule. The Peto rule basically stops you doing anything until you get to the end, whereas the Ibrahim Fleming sort of puts a brake on you making an unfortunate early decision, but then gives you more power. The consequence is your final test might be notionally significant to 5%, but not meet this rule because you've already spent some of your p-values. That's the kind of language that gets used. It gets you in trouble if you don't have exactly 5 data monitoring committees, for example, if you then go on to 7. And of course, yeah, there are variations on this that take that into account. Needless to say, the Bayesians got in on this, and there's various approaches, but one of them, certainly promulgated by sort of David Spiegelhalter and Max Palmer and others, is you think of having what you might call a skeptical prior that again puts a brake on you making a decision too early. You can also have an enthusiastic prior, and the idea is if the data has overwhelmed that, you might think about stopping. And there's quite a nice tie-up, and there's a nice paper again by David Spiegelhalter some decades ago, showing that essentially if you choose the Ibrahim Fleming rule, it's a bit like this Bayesian rule, and if you're Peto, it's a bit like a different kind of prior. So, you know, there's some subjectivity about whether which rule you choose. But the limiting factor for the kind of trials I'm involved in is this is all wonderful, keep PhD students or master's students busy for hours, but it's typically based on one efficacy endpoint known as the primary endpoint, which is the outcome to which you've nailed the colours of your mask for your trial, and safety is only addressed less formally. So if you've got a 2-group trial with one primary endpoint, you've got, you know, quite a nice basket of tools that are well established. But if you're doing anything more complicated, then you've got to start thinking again. So examples of simple trials that I've been involved in. I've done quite a lot of work in cystic fibrosis, which is a genetic condition. And one of the many things patients with cystic fibrosis have to do is take a lot of antibiotics. And that there's a huge question about whether they're overburdened with treatments. So something as simple as whether you take a thrice daily regime or a once daily regime, which would lessen the burden, becomes really quite important. And the topic trial addressed that. The primary outcome was change in FEV1. If you've ever blown into one of those machines, you go, it sort of is a measure of how fast you're blowing. And the change in that can indicate your treatment has to be adjusted for all sorts of things like age, sex, and height. And that's the primary outcome. Now, this trial is actually powered for equivalence because what they're interested in is that the once daily wasn't too much worse than the thrice daily. But actually, so from data monitoring terms, it was actually unlikely to stop. We didn't do anything very formal. The real issue was that these drugs have what are called ototoxicity. They can damage your ears. But actually, although we were meant to be monitoring that, the data on that was nowhere near good enough. So there was this tie-up between your sort of formal rule, but on the primary outcome, but actually it was the safety that was at issue. And we felt the trial really did need to continue long enough to get good safety data, because the hearing data is unlikely to emerge until some while after the treatments. It's not the first thing that shows up. And then another trial I was involved in very early on was a trial in esophageal cancer, which is the top bit of your gullet. And that was dealt with, at least for these patients, by surgery. But the question, which is quite novel then, it's much more widely used now in all sorts of cancers, is whether having some preoperative chemotherapy helps. And the rationale for that is, I'm not a medic, unlike our last speaker who is, but my understanding is that the preoperative chemotherapy shrinks the tumour, makes it easier to operate on, and might help survival, but of course it delays the surgery. So again, trade-off. The primary outcome is survival time from randomisation. Very important that it's not from surgery, because by definition you've delayed your surgery. And that was one of the first ones I was involved in. I was 25 years ago. I was still a gung-ho, I'm still a Bayesian, but much more gung-ho. But anyway, we actually did, it was one of the first trials that had Bayesian data monitoring done for real, as opposed to as a sort of hypothetical thing done afterwards. I think there was that in the chart trials. So again, if you're interested in the details, Peter Fairs and Max Palmer and I wrote up something in tutorial form to say, if you want to do Bayesian data monitoring, this talks you through. And we'd done some, and it's a theme that will come up, we'd done some sort of simulations to show the clinical members of the data monitoring committee what was involved and how the data might be presented, and some scenarios. And that's what we could then use to write up the tutorial paper. And that, I learned an important lesson then, that actually that pre-thinking prepares people that when they hit with the real data, they can then get on and think about the data rather than agonising about, well, what does this all mean, or what are these funny kind of curves? So a good lesson, especially when we get to more complex trials. And that was used in the skeptical prior sort of approach. So, when 25 years ago, I got asked to do nice, simple trials. I mean, it didn't feel simple at the time. I was petrified because it was real-time decision-making and I wasn't that senior. These days, I get approached for the more difficult ones. So the one that's got me thinking is that I've got a colleague who's, she was here, she's now in Australia, very interested in some of the things that help predict dementia. And it turns out that a lot of the things that help predict dementia are some of the ones that also affect heart disease. And it's not surprising, because a lot of them affect blood flow, and the blood flow to your heart is affected by the same kind of things that affect blood flow to the brain. But there's a lot of things looking at how you prevent dementia. And one of them is the idea of a long-term blood pressure lowering trial using a polypill-like triple dose combination to prevent dementia. But of course, when the clinician happened to be in the UK, and he talked to me about it before they actually asked me to chair the data, or chair the data monitoring committee. And although we haven't started yet, what he was saying was, we're going to have all of these different outcomes. Yes, we're going to have dementia because that's what we're trying to prevent, but we're also going to have the strokes, and there are different kinds of strokes, heart disease. So we're going to have to monitor those, because it's no good preventing dementia if you're doing some harm to other things first. So when he approached me, I said, you can think very carefully about that. And of course, I get a call saying, oh, you're just the person we need to help us think through what we're going to do. And I think they're doing pilot studies first, so I've got some time. But this is what has got my brain activated. This is my dementia prevention strategy. So this is why I sort of thought, when I was asked to talk here, I thought I need to get my head around this in a slightly more systematic way. But just some other examples of trials that weren't completely straightforward. Another one, in fact, I was involved in about 4 trials of people with depression. And you'll notice that there are 2 questions going on here. One is ketapine versus lamotrigine compared to ketapine alone, and the other one is folic acid versus placebo in people with bipolar depression. So that's multiple treatments, which was handled by a factorial trial in that particular case. I'm going to say more about the Women's Health Initiative study in the States, which was looking at major health issues causing morbidity and mortality in postmenopausal women. And I mean, when I had some involvement in this, and I had some involvement in a UK study that, again, I'll say more about, it was very few people doing it. Now, of course, the menopausal stuff has suddenly become fashionable. I thought, oh, it's time to look at some of this again. And the issue about the Women's Health Initiative study that made it fascinating is there are multiple treatments and multiple endpoints. I'm going to give some more detail about that in a minute. And then much more recently, I've been involved on the data monitoring committee of the principal trial, which is in COVID. And again, I'll say a little bit more about that shortly. But those are, and that's got multiple endpoints and it's a platform trial. So you can see all of these, I've picked just exemplars, and they were by no means the only one I could have picked, to show that there are plenty of trials which either have multiple endpoints or multiple treatments or both. So your Brian Fleming doesn't get you off the starting blocks. So I'm just going to pick up two issues to go down more. So the first one is the multiple endpoints. So as I said, it can arise in treatment trials, but I think it really crops up in prevention trials. And actually, I haven't put it up, but the other one that I've just joined the data monitoring committee for is a trial called trial of a procedure called GRAIL, it's Galeria trial, which is a screening trial for multiple cancers. So that's got multiple endpoints writ large, and I've been going through all sorts of things, having to sign confidentiality stuff because there's a company involved. So I haven't yet got my hands on the full protocol, but I'm expecting to have to, there's a lot of thinking being done on this, and Peter Sin is involved, so I'm sure it's been done well. But in prevention trials, it comes up a lot. So what are the approaches? There are probably, I think, at least three in common use. One of them is composite endpoints. You know, Stuart Pocock will have heard him talk about these. And there, the logic goes, and I'm parodying only slightly, we're trying to prevent heart disease or treat heart disease. What we're really trying to stop is the deaths, but these days there aren't too many deaths because we've actually got some quite good treatment. So we're going to look at the non-fatal heart attacks, and then we find there aren't as many of those as we'd really need in order to power the trial, which is good for the patients but bad for the trial. So let's add in some, let's put in some milder things, and they all get added together. And there's a dilemma because you're assuming that the milder things act as surrogate, and indeed, if you just naively add them together, that they are as serious as the more serious endpoints. So, but that's one approach. And if they're all pulling in the same direction, that's not too bad. The second is you may have some kind of hierarchical testing strategy, and I'll show you an example of that later. So you look at one of them, and only if that shows something exciting do you do formal testing on the next one. And that makes some assumptions that one of them is a kind of gateway to the next one. But some of the most interesting ones are where you've got trade-offs. So you've got some pulling in one direction, some pulling in another, and you certainly don't want to just add them together. And it's probably a bit naive to add in some and subtract off others. And that does start you thinking about trade-offs and weighting. So what I want to do is this is just an observation, is that, again, declaring my biases, decision-making uncertainty can be done all sorts of ways, but it's certainly closely aligned with Bayesian statistics for decades. And actually, one of these authors I was amused to see open this building earlier this year. So, somebody who once spent his life doing Bayesian stuff, now president of the Royal Society, and goes around opening buildings. So you're in good company here. But there's growing applications of real-time decision-making. So for anybody seriously interested in this stuff, there's a literature. But what I want to do is to go through, and initially I'm not going to think about data monitoring committees, I'm just going to think about the trial, almost the primary analysis, but then I'll get back to data monitoring committees. Starting with a simple example and building up just to get you thinking about how we do trade-offs. So a drug that will be well known to at least one person in this audience from the regulatory side, I don't think they've taken it themselves, is trastuzumab, which is a monoclonal antibody for primary invasive breast cancer. And there's some fancy diagrams there that I've got no intention of explaining, except to say that there's very good science behind it. But as a statistician, I should say I was involved in drug regulation. I was on the relevant regulatory committees for, well, over 20 years of my life. So this comes from that period. But these data that I've used are all public domain. And the issue is that there is a benefit. So the simple data as it first came through basically said for women who take placebo, about 20% of them, 22%, will get either disease progression or death over 2 years. And if they take the drug, that will go down to about 14%, so quite a big drop. And the proportion of deaths due to any cause will go down from about 2.4% to 1.8%. So that is all good. And on that basis, the media, Mail, but wasn't Mail Online in those days, but yeah, the Mail, Daily Mail were outraged that this was not available to all women like that. But the dilemma was that, or the thing to be aware of, was that like many drugs for cancer, they can cause cardiotoxicity, in other words, problems to the heart. And at the milder end, it takes it up from a rate of about 1 in 200 in that population to about 3 in 100, so a 6-fold increase. And at the severe end, it goes up 10-fold, which sounds dreadful, but that's only from less than 0.1% up to about 0.6%. So in absolute numbers, these are small, but they need to be taken into account. And so the question statistically is how? Now, much loathed by a lot of respectable statisticians is the numbers needed to treat, and much loved by people who like simple things. 1 over the change in the benefit on treated versus control gives you the numbers needed to treat, and there's an equivalent numbers needed to harm that is meant to give a simple idea of how many patients we have to give this to harm. So I won't go through the algebra, but I'll go through the examples. So for trastuzumab, it works out that for every 13 patients treated, 1 will benefit from a progression-free survival. So that in itself is quite a combined endpoint because you combine the progression and survival. And in terms of harm, for every 40 patients treated, 1 will experience cardiotoxicity. So if you're trying to explain to a woman what trade-offs, and this is where it does start to get similar to Maria's talk, what you're saying is that your chances of benefiting and your chances of being harmed are actually both quite small. You're not going to do too badly if you don't take it, but your chances of benefiting are rather larger than your chance of being harmed. So yeah, I think on that analysis, I don't actually think this is terribly difficult. This is in many ways a pretty good bet. But the question is, if they'd been closer, what would we be thinking? And the MHRA assessment report, and I wasn't involved in writing this, but it said that if they were combined into a single endpoint, it would be dominated by disease-free survival with a hazard ratio favouring the drug. But that makes and that's true, but it makes a very strong assumption that I want to call out, which is it assumes that you are equally favourable or worried about progression, a cardiac event and death from any cause. And that's not reasonable. So the question, and this is actually a slide that goes back for a presentation with Rob Hemmings, who was at the MHRA at the time. And his nice idea was, could you estimate a weighting that would need to be given to make the benefit risk unfavourable? Or what instance of cardiac events would you need to make it unfavourable? So you could use that kind of weighting as a sensitivity analysis. I think, in fact, once I learned that cardiotoxicity is actually quite treatable, so long as the doctors are monitoring for it, can spot it, which is the real lesson there. And most people probably would weight that less than at least the milder ones, less than a progression anyway. So I think, if anything, that would probably make Herceptin look even more favourable. But nevertheless, as a thought exercise for a relatively simple trial with essentially 1 good outcome and one side effect, that illustrates the ideas. But it's about to get more complicated because more generally, and this comes from an example of HRT, I'm taking this, I'm well out of it now, but I'm taking this menopausal theme rather seriously. And Cassetta Millenni, who's actually now a colleague of mine, but I think at the time was an MSc student with Keith Abrams, did a very nice MSc project that got published in the BMJ. And it's got such wonderful slides, which is why I still use them from time to time. And there are various decision models you can do. And again, the references I put on an earlier slide will point to that if you're seriously interested in this. But the idea is that you can add up the benefits, take off the harms, and that's your net benefit. So at that level, that's pretty simple. So for hormone replacement therapy, it's used for 2 things. It's used for symptomatic treatment, which is in itself a basket of stuff. So sort of hot flushes and you're feeling tired and lethargic and feeling like life is awful. and some more specific things as well. But it was also, sort of some 20 years ago, very much being touted for, and we'll come to the trials a bit later, being used because the evidence was that it seemed to prevent heart disease if used in the long term. And that was an observation from observational data, which is why it was put to trials. So this is really talking about longer term use of HRT. And there's no doubt from the evidence that the benefits are that it improves your rate of hip fracture, improves your rate of, reduces your risk of colon cancer and endometrial cancer. But the data that was coming out of the trials by the time this was published was actually, it didn't seem to be preventing coronary heart disease. It seemed to make it worse. It gives you more chance of a pulmonary embolism, more chance of a stroke. So there are trade-offs. Now, you could just add those together, but most people don't feel indifferent to those. So what you need to do is to take the risk reductions and then multiply them by QALY, which is a measure of the quality adjusted life years, which is an economic thing, which helps give the weighting. And what they also did was to bring in menopausal symptoms, so relative risk reduction times of QALY lost. And in particular, they were focusing on the breast cancer risk because there's an increased rate of breast cancer, which is what they saw as the dominant risk. So this analysis really explores that.
5 minutes as we have time for questions, because there's definitely going to be questions.
Okay, that's fine. So so what this goes through is showing that if you don't factor in the menopausal symptoms, then it's almost certainly harmful. But if you do factor in the menopausal symptoms, and if you're at a normal risk of breast cancer, it really carries on, it really is beneficial. And it's only if you're really quite high risk of breast cancer that it starts to be non-beneficial. And she then shows very nicely that depending on how you value the menopausal symptoms, if you think they are making your life hell, then actually you should almost certainly take it. If you think that you barely know whether you've got them, then actually it's almost certainly harmful. So there's really nice graphical displays there. But the Women's Health Initiative trials actually show that what they did was to take hormone replacement therapy to look at one basket of stuff, the coronary heart disease incidence, hip fracture and so on, then dietary modification, looking at essentially the same basket but in a different order, and then calcium plus vitamin D. But what they interestingly didn't look at in the trials was the symptoms, which is just balmy because it's actually the main reason most people take it. So interesting look at the data monitoring planning for the trial, and again, I'm not going to go into details, is that you could either take a purely global approach, which is sort of total mortality, or for each arm, and again, this factorial trial, you could look at the primary outcome, or you can take unweighted combined indices, weighted combined indices, weighted combined indices with Bayesian monitoring, or mixed approaches. And the point is for the data monitoring committee, who have to make a decision in real time, it really matters. And there's a really nice paper by Lawrence Friedman, who did work with their data monitoring committee that went through the scenarios, the different weightings, what decisions would we make, and show that it really mattered. And so you've got to do your thinking now. For simple decisions like the trastuzumab, you can kind of see it. You didn't need me to go through that. But for these ones, you really do need to get your thinking straight. And I think they pulled the plug on that trial too early, actually, in hindsight, because on the basis of that, the UK's trials that I was just getting involved in, they were just going to do our scenarios with them. They pulled the plug on because the Americans pulled the plug. And I still don't think we really understand about HRT and long-term risks of heart disease. So that's a downside of data monitoring committees that haven't done their thinking. But it wasn't for want of statisticians trying. So the second complexity I wanted to highlight was multiple treatments, which can arise in treatments of combination therapies and arise increasingly in platform trials. You can do, and I've shown some examples of factorial trials, you can do umbrella trials, where you've got lots of treatments in the same trial, and increasingly adaptive trials where you're tinkering with the randomization as you do some learning. And I chaired, or co-chaired, I should say, a very good workshop at the Academy of Medical Sciences, and again, the reference is on there, in 2019, which was very prescient. And we had Stampede, which many of you will have heard Matt Sides talk about, which is looking at multiple therapies in prostate cancer, and it drops some and then has others, and depending on what kind of prostate cancer you'll be eligible for one or more randomizations. Focus 4 looks at metastatic colorectal cancer. I chaired a data monitoring committee for ALICE, which was a pandemic influenza trial. We sort of missed all the peaks because we were so busy sorting ourselves out. So that didn't work terribly well, but it exercised our brains. And there's another one on dementia prevention with Bayesian monitoring. But it stood us in really good stead when the pandemic hit, because pandemic hit in January, we locked down mid-March. By 3rd of April, letter from the CMOs of all 4 UK jurisdictions saying, out of preference, please send your primary care patients into principal, your hospital patients into recovery, your intensive care patients into remap cap. These are the 3 national trials. You'll have heard huge amounts about recovery because they've been really good at publicising it, despite the fact it's frequentist. Remap cap has made a lot of things. And again, I won't go through the details, but recovery, and I have to, every time I use a slide like this, I have to check. They have to date randomised 48,000 patients. The red are the ones they've stopped for futility, the green are the ones they've stopped for benefit, and those are the current randomisations still going on in the hospital patients. So the learning from that trial fed straight back into patient care. And they've published a very nice paper on the data monitoring, going through some of the issues that are coming out, actually reading through them, and I won't go through them in the interest of time, but most of them actually aren't to do with multiple stuff. They're to do with doing data monitoring in a pandemic. But they do, interestingly, say employing factorial designs where appropriate actually would also be helpful. I think remap cap is a much more factorial trial. I chaired the principal trial. It took longer to recruit, but it was currently at just under 12,000 patients. We were far better at stopping treatment. Well, hydroxychloroquine was stopped by the MHRA on the basis of observational data. I mean, it's not a good treatment, but it shouldn't have been stopped on that basis. But the others were definitely stopped futility. We stopped in HELB-UDES-9 for benefit, and I'll come back to that just briefly. And it's not currently randomising, but there are some things still in follow-up. But that was both multiple endpoints and multiple treatments. So it had co-primary. It originally wanted to look at hospitalisation and death, because that's what the government cared about. Not enough of those, so they started to look at time to recovery. Had a gatekeeping thing. Actually, the 2 aren't terribly correlated. So we stopped UDES-9 on time to recovery, but it means we never got an answer on hospitalisation, which I suspect is why it's not widely used. And they then tightened up their criteria. New treatments are added in. You've then got a Bayesian model with time machine component, but you've got to think about how you factor in the fact that some of your controls are not contemporaneous. But it's very much a play the winner. It puts all the patients into the one that's going to win to get an answer to feed into the pandemic. So you do need to evolve your rules. We end up doing sensitivity analysis of contemporaneous controls because the TSC wanted those. And one of the things I grappled with was how much information you give. Normally you release your information when a DMET calls it out, but you can't do it when you've got ongoing things. And even the adaptive randomization ratios are potentially informative. So we couldn't even give the numbers in the trial to TSC, which upset them greatly. But and you can't give the control stuff because it's then still going to be used. So there's a lot of other things. So my interim conclusions, because obviously DMAT can't make final ones, is if you are asked to do it, check you understand the purpose of the trial, check you understand the decision guidance, because it may not be what you think it's going to be. For complex trials, it really matters what you're thinking. And so you have to do your homework before interesting data arises. Bayesian approaches are great, but other approaches are available. As a statistician, your job is to get your head around that, communicate primarily with the other members of the DMEC, but you need to ensure lines of communication are well established, because when you do call it, it's, oh, well, who do we do and who do we email? And we now got that down to a fine art in principle. We didn't for the first couple. So sorry to race through that last bit, because I should have stopped by now.
Well, thank you very much.
I thought I'd cut the slides down.
It's only because I know I genuinely have questions, but does anybody else have any questions from the floor first before I just start going off one? I'm on for the chat here just to see if there's anything from the I'm going to jump in then, if you don't mind. It's about the first point there. Check you
Yes.
understand the purpose of the trial.
Yes.
Because you mentioned about principle, which is what
Yes.
you did, and you said that was primary care, correct?
Yes.
You said it was more difficult to recruit. And I'm thinking, is that something about the particular route that patients were going? And like, when would you find out they had, COVID or whatever? Was it just like more testing and stuff? So the phenomena in real life and what you're trying to do with it, and what we're telling people to do, affects how you can recruit and how you can even
Well, it
study.
does. But if you're asking the question about do these treatments work for people in the community, it's not the right trial. If you're the NHS and you want to know should GPs be prescribing it, you're only interested in patients who get to the GP.
Yeah.
And actually they did do, I think there's more innovation in that than some of the others, because they've now got innovative routes they were taking straight off the apps, including Zoe. So they almost bypassed the GP sites. I think what they've done there is set the ground for other trials in primary care. But it was slower off the ground. Whereas I think the hospitals are set up, they have protocols
in place to ramp
yeah.
up. Sorry, lots of thoughts got
Yes.
So in terms of there's almost like meta decision making in a way, because it's almost like the decision making you have to make in advance. Oh, absolutely. But then you went there.
Yes.
But it's like that whole thing. How have you found communicating the difficulties in making decisions about future decision making?
Yes.
How have you found communicating that to both clinicians, but even also to statisticians who are used to just doing stuff that they're told to do?
Yes, so I've been working with very professional trial teams. We're working with the clinical trials unit in Oxford, not the same one as one that specialised in primary care. We were also dealing with Berry consultants, so some of you may know the name Don Berry. Well, I've been working with both his kids, and he's now got 2 grandkids employed by the firm, as well as a whole lot of other people. It's a very big firm doing a very professional thing. So there, the communication was great because immersed in it. It was communicating to TSC, but again, there was Matt Sides as an independent person, which helped enormously because he gets platform trials. But yeah, the clinicians, I think, were a bit bamboozled. But we talked it through, and because we met almost weekly in the height of the pandemic, because the speed of recruitment did really peak. Actually, we had a chance to sort of go over it thoroughly, and we adapted and got better reports. So by the time we did have decisions to make, we were well in it. But it was
just picking up on your communication and the question you asked the first speaker, how do we inform patients of what's happening to them on a trial when it is so complex and you're using more than just statistics, more than just percentages and data?
Yes, I think for the patients coming in, what they need to know is at the moment we're uncertain between these 3 treatments. Only one patient went in at a time, and there might have been 2 treatments being randomised, and that might have been 3, and they would know that that was what they were being offered. How you feed back results is a slightly different question, but I have to say that I was asked, I don't do too much media work, but I was asked on the radio because Test Gel had talked about the benefits of platform adaptive trials before she died. And so there's huge interest. She saw them as, I can try this treatment. If that doesn't work, I try this, then I try this, which is a strategy. It's not what we normally mean by platform trials. So I had to sort of do some unpicking of that. And that was a lesson to me that what I thought was straightforward wasn't to her. But on the other hand, it was great to hear her, really talking about the value of trials. So it was a slightly, poignant thing to have to do. But I think we got there. But I think being prepared to do radio things and talk through complex ideas, obviously I didn't go into all of this, but you take the central thing they're concerned about and just talk it through gently is important.
Mona, go for it.
So in simple trials, okay, you know what you're getting into when you sit for a DMAC basically, and how do you decide in complex trials how frequent and when to call on the DMAC basically? So that's one question. And my other question is, your third point basically, different approaches can yield different results. How do you decide which one to go for?
Right. Well, I think in some ways the answer is the both, which is a lot of pre-thinking and simulation. So certainly for the trials I've been involved in most recently, most of the thinking has been done by the design team. The data monitoring committee to a large extent are implementing. They may challenge and ask questions. But again, Berry consultants have done a huge amount of work of simulations, which we had access to, of how often you need to monitor, and it's based on power, expected accrual and so on, but it needs writing down. And I think with the multiple endpoints, there's no substitution for doing some hard thinking. There's no easy answer to how do I trade off these things, which things to drive the data monitoring committee. And what I didn't go into, because this is a half-hour talk, not a 3-hour talk, is that you've often got some of that information very early and others are longer-term risk. And how do you model that this information is coming in now, but actually it may be preventing something coming further downstream? I mean, that's really difficult. But the more you do your thinking, the more you've then got your eyes open when the data starts coming in. But the simulations can be really helpful in that, properly presented.
So am I hearing from you then that, all the thinking, most of the thinking, not all of the, most of the thinking has to be done by the team?
Well, it does, but the data monitoring committee have to understand that. And I mean, one of the things I insist on, I couldn't hear because we're in a pandemic, but normally if I'm on a DSC, we try and have a joint meeting with the trial steering committee before there's any data, so that our understanding of what's driving the trial is what they're doing, because sometimes the reports are somehow copied and pasted from a previous trial, and actually they may not be appropriate anymore. And I even read they will have charters now, and I read and think this is not appropriate for this trial. It's so just that kind of pre-work really sets you up. And you can ask those things. Often trials are quite naive and don't think about that. And as a DMET person, you can just look, it'd be really helpful if we did this.
Can I just quickly comment? I think what you're saying there, Deborah, comes back to your first point there. Check you understand the purpose of the trial.
Yes.
And that's not the same thing as reading the objectives section.
No.
What really is the purpose?
Yeah. Where does it fit in? Where does it fit in? Most trials in drug development, for example, are part of the whole sequence. And this is informing that. And what do we really need to know, and what sort of a secondary benefit?
We have Paul's questions there just in the interest of time, but we can do is we can note them in the chat, and maybe Deborah, when we're sitting down later, we can have go through them. So one final thank you again, just to Deborah.
Thank you.
I'm very fortunate to actually have seen Andrew speak quite a few times on this topic, and it is a very I really like this particular presentation and the topic itself, and I'm sure Andrew's going to say this as well, but you can't just sit down and just be quiet for this presentation. It is going to be somewhat involved. So you have to keep your thinking hats on throughout the whole thing. Andrew, as the slide suggests, he's in the Memorial Sloan Kettering Cancer Centre. He's been around the world looking at this stuff. And no, I'm from what I remember of the presentation, Andrew's going to go through the kind of history of this question anyway. So without further ado, Andrew, I'm going to leave it over to you.
There you go. Thank you. You can hear me okay? Okay, and if I move my cursor around, you can see that on the screen. Very good.
No, we can't.
Yes. Sorry. Oh, all right. Well, I won't. Can do that. All right. Well, we'll not have to point at anything. Very interesting to see the prior talk. I mean, I'm delighted to hear a former president of the Royal Statistical Society, say the word decision making or use the word net benefit. One of the stories that I tell is that as a statistician interested in decision making, I would often go to the International Biometric Society meeting, and I'd also go to the medical decision making meeting. And I started to notice that these were always on opposite coasts. One would be in Pittsburgh, and the other would be in LA, and then the next year one would be in Miami, and the next one would be in Seattle. It was almost as if, in case the decision making people and statisticians met each other in the airport, that would be some kind of problem. A lot of my career is trying to insert decision analytics statistics into traditional biostatistics. I do like being interrupted. I really don't like at the end of the talk saying, you had a sort of slide, it was about halfway along, and there was a sort of graph thingy with a number on it. And, so do interrupt. I'm actually also going to be want some feedback. I'm going to be asking for some. I'm going to ask some questions. I want people to, I'm going to say, what's better, A or B? And really like to hear what people have to say and why. So I don't know what your setup is in the room is, whether there's microphones or if, but that it really works. So this talk is about prediction. That includes diagnosis, prognosis, whether you've got a test, a model, or marker, whether it's AI or ML. Completely agnostic to how you're making your prediction. or whether that's something that you could in theory know now, diagnosis, does the patient have cancer, or something you couldn't know for several years, for example, whether the cancer is going to recur. The idea is you have some information now and you're using that to try and make a prediction about some information you don't have. So I was very influenced by this man, Mike Catan, who's now the chair at the Cleveland Clinic. And he asked a very, very simple and obvious question, that a clinician comes to you with two statistical models or two diagnostic tests, want to know which one to which to use. What statistical method do you use to help answer the clinician? Right? Nothing could be more basic. And I'll give you a little example. So here's the clinical scenario. As you may know, many men who aged over 50, aged 50 to 70 or so, go and get their blood checked for a protein called PSA. And if that's elevated, that increases their risk of prostate cancer. But most men with an elevated PSA do not have the kind of aggressive prostate cancer we really want to find. They either have no cancer or the type of low-grade cancer we'd really not know about at all. So let's just imagine some statisticians come up with an idea, which is instead of what we do now pretty much, which is biopsy all men who have an elevated PSA, let's use a statistical model to predict who is at high risk of an aggressive cancer and only biopsy those men. So here's model A and here's model B. I've given you the calibration plot. I've given you the area under the curve, the discrimination. What you can see is that model B has better calibration but poorer discrimination than model A. Put in some other things. I gave this talk in at University of Copenhagen where they love the Breyer score. So the Breyer score, I put the Breyer score in there. Someone was telling me the only thing they really look at was the R squared, right? And I never really understood R squared for a binary endpoint, but I put it in. And Frank Harrell, a very well-known prediction modeling expert, said it's all about the variance of the p hats. So I put that in. I don't know if we've got any. Do we have any sort of ML folks in the audience?
There were some here a while ago. They've just gone, I'm afraid.
They left, yeah. As soon as they knew I was coming, because I'm a bit down on ML. But they have something called a precision recall curve. I think precision sensitivity and recalls positive predictive value or something. I always sort of forget which one's which. But that they've decided to abandon, forget that we've been doing this in biostatistics for years and just start again from scratch. So I have a precision recall curve. So if you're interested, here's the precision recall curve for model A and model B. But here is a question, and I would like some feedback on, should you use model A or model B or no model, right? Maybe we're just better off biopsying what we're doing, what we do right now, biopsying everybody. And so, let's have some feedback. Which is the better model? Should you use either model?
Go for it.
I'd use the one that's cheapest.
Cheapest. Well, they're models, right? So they're not. Let's just assume that they're routinely collected data. PSA, your age, whether your clinical exam findings. So that let's assume that they're equivalent in cost for now. We'll bring in the issue of cost later, actually, but assume that they're of equivalent cost.
Well, can I answer again? My real answer is I don't care which one you use. Hence, use the one that's cheapest. So I suppose I'd step back and say, actually, I think use either.
Well, okay, but then give a rationale for that. What about this tells you that the two are equivalent? I mean, what are you looking at here that tells you that the two are equivalent?
The AUCs are the same, the pseudo-R squares are the same.
No, they're not the same, are they? They're not. One's 0.18819 and one's 0.793.
That's what I said.
Right?
They're the same.
Well, I don't know. Well, how you're saying they're the same? They're obviously not the same. They're not identical. So, how much of difference would make a difference? I mean, if it was 0.85, would you say that it was the same?
Okay,
Model A was 0.85.
Somebody else.
Okay. Was it okay? I just want to point out. So there's I'm not trying to pick on anyone, and I certainly don't want anyone, I'm really trying to explore these questions. I mean, and it's an important one, I'd probably say I kind of, I've been looking at AUCs for decades, and I've got sympathy for you. For what you're saying. Yeah, these are about the same, probably no big difference at all. But it does raise the question of how much of a difference would be a difference. And if we say, well, 0.05 or 0.06, well, okay, what's that based on, right? Do we have any other thoughts on which is better, Model A or Model B? Either online or in the audience? Is anyone worried about the calibration? I mean, you say that the previous respondent said they're about the same because the AUC is the same, but the calibration's worse for Model A. Does that worry anybody, that level of miscalibration? You're
It's better in another part of the curve.
Yeah.
Sorry?
Those with the high risk.
Yeah, so it depends on which area of the curve. Yeah, so it depends on which area of the curve, right? So that's true, but you've got the figures in front of me. You've got to answer the clinician, right? I'm a urologist. Should I use one of these models? What would you say?
Could you not use a sort of super model which would have A and B in it, and then test one compared to the other one?
I mean, we could always create a new model. That's true, right? But the urologist, this is what's in the literature right now. We've done our external validation study, and the urologist has a patient coming in tomorrow. Yeah, I mean, we can always kick. Statisticians are very good at kicking the can down the road, right? We failed to reject the null hypothesis, but the problem is that, thousands of men are getting PSA tests every year and, turning up in clinics, and we need to know what to do with them, right? And so if you're saying, let's build another model, that's basically saying, or combine the two models, that's basically saying, let's just carry on, don't use either model, let's carry on biopsying all men with an elevated PSA. Well, why don't we move on? I mean, and we'll give another example. Now what we have is, let's just assume that one of those two models, one A or B, whatever it was, everyone decided, that this really was the best model, and they started using it in practice. And so just routinely men come in and that this model is used to predict who has biopsy. And then a group of researchers come up and they say, well, actually what really matters in prostate cancer is prostate volume, because it's whether it's benign or a malignant transformation, and volume will tell you about that. So we'll give you a transrectal ultrasound, and we'll use the information from the prostate volume in our model. And the problem with that is that a transrectal ultrasound means putting a probe up your backside, which is you have to come into a hospital, and it's not very comfortable, and it takes time and a technician and an ultrasound machine. So as you can see, it improves the calibration and discrimination quite a bit. I did actually have a statistician try to explain to me why the standard model plus the uncomfortable test was worse. I still don't understand why they say that, but I mean, it does, if you look at all the figures, it does seem to be better. But which one should we use then? Any thoughts? Should we use the standard model, or should we switch over to using the one that incorporates this uncomfortable test? Any thoughts on that? I want to talk about what your thought process might be. Any thoughts? Yeah, I mean, it's difficult. It's like, how do we rate? Okay, the AUC or the Brier scores goes down by 0.013, or the AUC goes up by about 5 points. How do we put that on the same scale? How do we say it's worth going through an uncomfortable test for an extra 5 points on AUC? It's pretty tough. I'll make this a really easy one. The next one should be super easy, right? Because this is a pretty good AUC. And it's pretty well calibrated. So here's the situation that, the man's now been found to have prostate cancer. So he's having a surgery. Do we do a lymph node dissection? We should only do a lymph node dissection if the patient actually has lymph nodes involved. So here's a model to predict your risk of having a lymph node involvement, and as you can see, pretty good AUC, and it's really nicely calibrated. Anyone thoughts on whether we should use this model, or even what they think if they read this in a journal, what the authors would say about it?
I think the authors would be really proud of their model.
Right, and they would say, "Please use it." Right? We think, and go to our online web calculator, right? Which you tend to see on after every prediction model. But any thoughts? Do you think that's justified?
It does look as though the straight line fits almost as well.
Yeah, I mean, the calibration's great. So, I mean, I think, yeah, I mean, I think I'm not there in the room. I mean, would I be right saying consensus is that this is well calibrated, reasonable AUC, so we should use it? Seems reasonable. Okay. Here's just a fourth example. Unfortunately, the man has now had a recurrence of cancer. He's dying. And so there's this thing that we do. It is for men with bone pain. We do this palliative orthopedic surgery. We're not going to do that if a man is at high risk of death within the next few months. It's just not worth it. You only do this if men are going to live 6 months or more. So there's this, on the left, we have our standard prediction model for how long somebody's going to live. And on the right, a new team has come along and they've said, well, you instead of just looking at the stage of the cancer or whatever it is, let's look at blood markers like LDH and albumin. And you can see you get this huge increase in the AUC, but you get some miscalibration. Any thoughts on whether that degree of miscalibration outweighs this big increase in AUC? Right? Should you use a model that's perfectly calibrated but has a poor AUC, or this one with much higher discrimination but has that miscalibration? Any thoughts on that? I mean, Frank Harrell. Sorry, go.
I worry a little bit about whether the perfectly calibrated one was overfitted.
Oh, this is all on external validation, right? Sorry, I should have explained that. This is all assuming external validation. Yeah, I mean, Frank Harrell, who, is a big hero of mine, says, do not use a model unless it's well calibrated. Never quite understood the criteria for what makes something well calibrated. But if you showed him this, he would say, absolutely do not use the model on the right. And if anyone sort of agrees with that. I'll just show you, because we'll come back to this later. Imagine this is a slightly different version of the blood markers model. And if any, I just screwed around a bit with the calibration, just a tiny bit. I cannot visually tell any difference between the two of those. And if anyone you can, but it's very difficult to see a difference there. We'll circle back to that. I think this is an absolutely massive problem. Okay, so what the basic thing we want to know about a model, these are models that are meant to help clinicians make decisions like, should I operate on a patient? Should I resect their lymph nodes? Should I do a biopsy on a patient who has an elevated risk of prostate cancer? And then we create these models as statisticians in order to help the clinicians make that decision. And then we present the statistics that we all learned at college and read in the textbooks that we're meant to present. And they're completely not fit for purpose. They do not answer the question that is being posed, which is, should you use them in clinical practice? Let's look at diagnostic tests. I've been giving this slide probably for 15 years. I once gave it at the National Cancer Institute to basically the chairs of the Department of Statistics at every major cancer center in the US. And I said, this is the prostate cancer biopsy example. And I go, here's 2 binary tests. Which one should we use if either? So has anyone got any thoughts on that? Which one we should use? Or what might influence your decision? Shout out. Yeah. Normally I get a lot of blank faces and I say exactly the same thing. So wait a minute. I went to college and you taught me to report the sensitivity, specificity, positive and negative predictive value for a binary test in order to say whether the test is any good. And then I come back and present these statistics to you guys and you can't tell me which is which test is better. I mean, that's a massive problem. So at which point then someone always says, well, hang on, it depends. It depends whether sensitivity or specificity is more important. And the answer to that is that almost always sensitivity is more important. In our biopsy example, this is a biopsy example, right? The false negative means you end up getting a biopsy, which is on the left, a little bit uncomfortable, hell of a lot better or less worse, shall we say, than the false positive on the false negative on the right, where you end up dying of metastatic cancer. But this is statistics. You don't just say, well, it depends. Right? We need a parameter and we need a formula. It goes back to, well, the AUCs seem to be about the same, or the AUCs seem to be a little bit better. That's not what we do as statisticians. We put numbers on things. If we go back to this point, we're thinking about clinical consequences. It's much worse to die of prostate cancer than to have an unnecessary biopsy. Traditional statistical techniques, AUC, calibration, the Breyer score, they do not incorporate those clinical consequences, and therefore they cannot guide clinical care. So I've started off by saying that the tools that we have, the accuracy metrics that we routinely report in the literature and we teach our students to use and all the textbooks, are unable to do the most basic task, which is to tell us whether a model is worth using or not. And then sometimes someone will yell, well, it depends. But we need a parameter for depends. And the depends parameter that I propose is the threshold probability. It's a very simple definition, as you can see here. If, for example, my threshold probability for a prostate biopsy is 10%, that means that if you tell me my risk of having aggressive prostate cancer is 10% or more, I'll have the biopsy. And if it's less than 10%, I won't. Now, this is a decision tree. Do I need to talk through this, or does everyone knows what this is? You tell me. What should I do? That everyone knows. Is that a thumbs up? We'll talk through it, or everyone knows it?
Everyone's good here.
Everyone's good here. Okay, so let's just imagine we didn't know whether to treat a disease or not. Here would be the decision tree. So you've got the prevalence of the disease is now your probability for each decision, each branch. And then the outcome is this utility. So we're just using one is the decision the first superscript is the decision you're making, and then the second one is, sorry, the other way around. It's the first one is, now I'm confusing myself. The second one is whether you have disease or not, and the first one is whether is the test result. So U11 is a true positive, and U01 is a false positive, and so on and so forth. Now let's assume that what happens if your threshold probability is at the prevalence? So you're saying, well, I'll get treatment if my probability of disease is 10% or more, and the prevalence of disease is 10%. Well, that means I'm indifferent, right? That by definition, I'm indifferent to the outcome of whether I get treatment or no treatment. So we'll just put in that case here. So what we know is that if you multiply get the expected utility for treatment and the expected utility for no treatment are the same. So that's that top thing. So the probability times the probability of disease times the utility of a true positive plus or minus the probability of disease, or the threshold probability times a false positive, and so on and so forth. You can do a little rearrange that, and you get the following formula, right? Which is that the benefit of a true negative minus the utility of a true negative minus the utility of a false positive divided by the utility of a true positive minus that of a false negative. And you can see that as the benefit of a true negative prediction divided by the benefit of a true positive prediction is the odds of the threshold probability. And that's a decision analytic result that's been known since at least the 50s or 60s. And it's something very intuitive, and it's something that we use in everyday life. So here's a very simple example. What's the probability it's going to rain? And what are we going to do about it? I want to imagine that here's two examples or two scenarios. One is we're going to have a wedding. And should we have waterproofing over our tent? And the other one's we're going to go a hike if it's going to rain. Excuse me. What we're going to do is we'll abandon our hike. Now, as you can imagine, if you take into account that the cost of waterproofing, right? So that's the and then think about the consequences, right? I mean, if it rains and you don't waterproof, you ruin your big day. It's a disaster, right? If it goes, rains and you're on a hike, it's really not such a big deal. And so, probably if there was only a 4 or 5% chance of rain, you might well waterproof your tent at the wedding, whereas you probably, I don't know, want at least a 50 or 60% chance of rain before you cancel your hike. So it's a very intuitive finding, well known in the decision analytic literature. Now, so how do we actually use that in our statistics? Is we have to solve some formulae, right? So let's think through again what our expected utility of test results is. So for a true expected utility is your probability times the utility, and so we have a true positive is we've got a little formula for the probability of a true positive, true negative, false positive, and true negative, multiplied by their utilities. If you're doing a test, so if we can just add all those up to get your expected utility, and we do a little bit of a rearrangement in that second line. And now what we're going to ask is, okay, what's the utility of assuming everyone is negative, of treating no patient, right? We're not going to do anything. And that's what you get below. And now we can say, all right, we can subtract one from the other. And what we can get is, what is the utility of doing some kind of test compared to just doing nothing? And that's where you get that's the top line. We can just do a little rearrangement of that. And then what we're going to do is we're going to put everything in the unit of true positives. And so what we have on the left-hand side is what we're going to call net benefit. And that's the utility of a test compared to doing nothing in the unit of true positives. And we have this equation on the right. Now, because I'm not in the, if I'm in the room, we could go through it, but it's still fairly obvious that what's the probability of, test equals 1 if the disease equals 1, that's sensitivity. Probability that disease equals 1, that's the prevalence. Then your probability of, the test is 1 if the disease, if you don't have the disease, that's 1 minus specificity. Probability disease equals 0 is your 1 minus the prevalence, and then you have this utilities. The little 4 utilities there. But if you remember those 4 utilities at that little equation there, u0 0 minus u1 0 over u1 1 minus u0 1, we already proved that was equivalent to the odds at the threshold. So now we have this equation. The net benefit is sensitivity times prevalence, which is true positives, minus 1 minus specificity minus 1 minus prevalence, which is false positives, times the odds at the threshold probability. The interesting thing about this clinical net benefit, which is what we have here, is that it's easily derived in an intuitive manner from the AUC. Here's the AUC. We're going to weight that by prevalence. It makes sense to say that trying to find a disease with a prevalence of 1 in a million is going to have a different benefit to finding a disease with a prevalence of 50%. And then we're going to weight by the clinical consequences, which, as we proved, is the odds at the threshold probability. And the nice thing about the clinical net benefit is there's a very easy, intuitive explanation. You compare that to AUC is the probability that in a randomly selected discordant pair, et cetera, et cetera. Okay, the clinical net benefit is the number of true positives per patient if the false positive rate was 0. And we'll give the worked example, and then we'll say we'll talk about what the net benefit means. So this was our percent free PSA, HK2. Always have the strategy of biopsy everybody, because that's what we're currently doing. And maybe there's a cynic that says, this is, don't biopsy anyone. You shouldn't even be doing this. You shouldn't even be doing PSA testing. And before we looked at sensitivity and specificity and all that, we looked at it and no one's, well, I don't know what to do. I guess it depends. Right, well, we're now going to put in that depends parameter, this threshold probability of 20%. The math is super simple. I've had some frustrations in my career when I've gone up, someone's given a longitudinal general estimating equations model, and then they've sat down and I've got up and I presented net benefit and they've said, oh, this is difficult. This is really hard. And I'm like, it's multiplication, division, and subtraction. It's really not that hard. So you can do the very simple math there. And what do you end up with? You end up with at this threshold of 20%, you said percent free PSA has a net benefit of 0.1256, HK2 of 0.0919, just biopsying everyone 0.075, and biopsying no one by definition has a net benefit of 0. And so we have an answer. If your threshold probability is 20%, you should, the highest net benefit you get is to take a free to total PSA ratio, and if that is positive, you do the biopsy, and if it's negative, you don't. Right? Now it depends, or I've got to think about it, or the two values see about the same. It's an unequivocal answer to the question. In terms of the unit, 0.1256 net benefit is in the unit's true positives. So what we can say is that this, if your strategy is to every man who's got an elevated PSA, you do take the free to total ratio, and if they're only biopsying them if they're positive for that test, that is equivalent of a strategy that for every 100 men who come in with an elevated PSA, you do 12, I guess 1,000 men would be easier to say. For every 1,000 men, you do 126, biopsy 126 of them, and all 126 of them have cancer. There's no negative biopsies, okay, because it's net. You can think about net benefit in terms of profit, right? So if I buy wine for $1,000 and I sell it for $1,500, I've made a profit of $500. That's the equivalent of someone just giving me $500. Okay. So your obvious question might be, well, this threshold of 20%, that's that might be your threshold. I might be really worried about cancer. There might be some old guy who's like, oh, I really don't want to have to go through this unless it's absolutely necessary. Well, what you can do is you can vary the threshold probability. And this is a decision curve. On the y-axis, you have net benefit, and on the x-axis, you have your threshold probability. And I've calculated the net benefit for every value of threshold probability. This it's nicely intuitive. So what does a low threshold probability mean? It means like there's really even a small risk of cancer, I'm going to want a biopsy. And what do you see? What's the best strategy is to give everyone a biopsy. If you're the sort of person that's like, no, I'm not going to get a biopsy unless I've got a 50, 60, 70% risk of cancer, then no test is going to help you. The positive predictive value of anything, no test is going to be that high, right? So just don't get a biopsy. And then you can see that you tend to use free PSA if your threshold probability is lower, and HK2 if it's higher, right? So you can see that's you're always choosing the strategy from with the highest net benefit, and it makes sense. The free to total ratio had higher sensitivity, and biopsy by HK2 had higher specificity. One nice thing also about the decision curve is that it's very intuitive in terms of some other statistics we use. For treat all has the equivalent net benefits to doing nothing at the prevalence. The maximum net benefit is also the prevalence, which sort of makes sense, right? So how many true positives? Well, if threshold probability is 0, which means we don't care about false positives, then your net benefit will be the prevalence for treating all. And for a binary test, it will cross treat all at 1 minus the negative predictive value and cross the treat all at the positive predictive value. And maybe why don't I explain those? Let's just imagine you a patient tests positive, and you say, okay, because you've tested positive, you now have 37%, your positive predictive value is 37%, so you have a 37% risk of prostate cancer. And they're saying, well, I need a 40 or 50%. Then don't use the test, right? The test is never going to help you. So that's why the net benefit of a test crosses the net benefit of doing nothing at the threshold probability equivalent to the positive predictive value. By the same token, it crosses the line of just give everyone a biopsy, treat everyone at 1 minus the negative predictive value. Again, let's think about it. Someone said, well, good news is the test came back negative. The test has a negative predictive value of 90%. So therefore, you only have a risk of 10% of 10%. That's really high. I still want the biopsy. Well, don't give the test. Just give a biopsy to everybody. You can apply this to a continuous endpoint. The nice thing in decision in this approach is that you're basically using the same threshold probability to derive the net benefit. As to work out who's a positive and a negative. If we choose, so here's an example, we're going to use this 20% cut point, and let's imagine we have an external validation study of a predictive model. We biopsied 1,000 men, we found 277 cancers. And then we said, well, we'll apply this model and we'll see. Let's just look at the men who had a risk of 20% or more. And there were 487 of them. 211 of them had cancer. And then you just do the net benefit calculation in the normal way. True positives minus false negatives times the odds at the threshold. You can, by the way, we've got this 0.142, which, as I said, is the equivalent of 14.2 cancers per 100 patients with no unnecessary biopsies. You can just reverse that very simply and say, well, right now we're treating all, we're biopsying all our patients. So now we just divide through by the threshold probability, and we can say, okay, if we use our model, this is the equivalent of biopsying 19 fewer patients for every 100 without missing any cancers. Right? So it puts it in clinical terms. So this is the formal definition of a decision curve analysis. We're going to select some threshold probability. We can discuss how that's done if you want in more detail. I would point this out. Some people have said, well, what if you don't have one? What if you don't know what the threshold probability is? If you don't know what the threshold probability is, you can't use the model, right? The model comes back and says, you have a 27% chance of having prostate cancer. You're like, well, I don't know, right? I don't know, should I get a biopsy or not? I have no idea, right? Well, then the model's useless to start with, right? You have to have a threshold probability to use the model. So we're going to select one. We'll define a positive test as if your predicted probability is equal to or greater than the threshold probability. Calculate the clinical net benefit, true positives minus false negatives multiplied by the odds at the threshold. And then we're going to vary that threshold because patients are different, preferences vary, preferences of clinicians vary. And you can do that over an appropriate range. And that's really not, it's less hard than it seems. I'll give you an example in a little bit. But I think for most decisions we make, we can say, well, not everyone's going to choose the same threshold, but there's some thresholds that are going to be pretty unreasonable. So let's put it in practice. Here's model A and model B, and you stared at that, and somebody said, I'll take the cheaper one, which assumes that they're the same, and that one, that they're both better than doing nothing. But, we looked at it for a while. I've had literally hundreds of people look at this and never be able to give me an answer. Let's look at the decision curve. You can instantly see that we should use model B. Model B is the better model. Okay, model B, it has a lower AUC, but the higher, the decrease in discrimination, it's a bit lower, but the calibration is really winning the game here. Okay, so why do I say model B? let's look at this is for aggressive cancer, and you can go and talk to doctors and patients about this, and they'll say, well, for an aggressive cancer, probably for most men would say a threshold probability of about 10%. Okay, I mean, aggressive cancer is bad. You really want to catch it, but if I don't do the biopsy today, I can carry on monitoring the PSA and perhaps do a biopsy in 6 months. And prostate cancer is generally slow growing, so I'm not going to miss anything. Yeah, there might be some patients who are anxious, so I'll use a threshold probability, less than 10%. I'm not going to do anything less than 5%. There's about a 3, 4, or 5% risk of sepsis after, sort of serious infection from a prostate biopsy. So I'm not going to do a biopsy, for any patients whose risk of cancer is lower than their risk of sepsis. And at the other end, I mean, if someone said you have 25% risk of high-grade cancer, and they said, no, I'm not interested in a biopsy, you really have to educate them on just how serious it is to get a high-grade cancer and, what a miserable death it is to die of prostate cancer. And so we're really looking, I've showed you, from 0 to 20%, but we're really focusing on this range of 5% to 20%. And what you can see is that the net benefit for Model B is the highest across this entire range. So it means that irrespective of the patients that you're seeing, if they're old and sick, or their preferences or the doctor's preferences, it doesn't matter what their preferences are. The net benefit, clinical net benefit of using Model B is going to be higher than Model A and higher than the alternatives of just biopsying everybody or biopsying nobody. Let's look at this scenario. The second scenario, everyone would say, oh yeah, well, I mean, the calibration's pretty good, and calibration's excellent, and the discrimination's pretty good. Here's the decision curve. This is not a useful model. You have to look pretty closely to see that the green line, the net benefit of the model, just about diverges from the blue line of give everybody a lymph node dissection. Now, the reason why that is if you look at the threshold probabilities, they're pretty low. Now, here's the reason why this is that actually taking out the lymph nodes from, if you take out lymph nodes in a woman with breast cancer, she can end up with lymphedema. I mean, all sorts of terrible things can happen. In prostate cancer, it turns out taking out the lymph nodes is not really associated with particularly severe side effects. Of course, if you leave in a lymph node instead of removing it, that can cause a recurrence. And so that's bad. And so you'll probably remove a lymph node if remove the lymph nodes if the probability of having affected lymph nodes is even 2%, 5%, 7%. There's even guidelines that use those numbers. So what we can tell here is for those threshold probabilities, the model is not of value. Here's the standard model plus the uncomfortable test. And the question, first question is the model better? Because as I said, some statistician tried to explain to me why it wasn't. Well, here's the decision curve. You can see that the new model is clearly better, has a higher net benefit. But one of the nice things that one of the participants mentioned the harms of a cost or harms of a test. Nice thing about net benefit is everything is in the unit of true positives. So we can just subtract off the harm of a test or its cost or whatever you like. And all we have to do is put that in the unit of true positives. So what you do is you ask the question, let's assume this new test with the transrectal ultrasound was perfect, right? How many patients would you give the test to in order to find one case, right? How many men would you put the transrectal ultrasound probe up their backside in order to find one aggressive prostate cancer? I'm going to assume that, doctors are going to say 30, 40, or 50. Anything more than 50, I think I'm, causing a lot of pain and inconvenience and wasting a lot of resources for not much. So you can just subtract out that. This is assuming that you do 40, so the test harm is 0.025. And you can clearly see that now that the net benefit of this new model that includes this invasive test is worse than the standard model. Okay, so we're not trying to say, well, how the AUC of about an extra 5 or 6 points, is that worth the pain of it? We don't have to guess anymore. We can actually put numbers on it, and we can get a clear and definitive answer. Here was the one for risk of death for candidates of orthopedic surgery. Very difficult to tell whether the increase in discrimination is offset by poorer calibration. In this case, the threshold probabilities, let's sort of talk about those for a bit more. It's really going to depend on the patient, how much pain they're in, how much they really don't want to be in hospital near the end of their life. So you can imagine some patients would say, I even have a 20 or 30% risk of death. I'm not going to go through an operation. And other patients are going to say, I'm in so much pain. If I die in 6 months' time, so be it. But at least the last few months of my life, I'll be in less pain. So we use this threshold probability of 20 to 60%. And you can see the standard model plus the blood markers is better across the entire range. And so we can say that you should use this the model with the blood markers. I showed you this where you can barely see a difference in the calibration. And in this particular case, you can see, what you see is that this new model with the blood markers, the net benefit is no longer highest across the entire range of the threshold probability. In other words, depending on the patient, sometimes the standard model will be better and sometimes this new model will be better. And what we conventionally say in decision curve analysis is it's unproven, right? That you shouldn't use this model because it's going to harm some patients. And you need to refine your model or do more research. So I think we probably want to give about 5-10 minutes for questions. So just in the last few minutes, do want to point out that a few last points. Decision curves are methodologically robust. This was, you might have heard of this minor disaster of the NRI, which was shown to be a very flawed technique. But as part of the theoretical work on that, they did show that net benefit is a proper scoring rule. It could easily extended to time to event data, a competing risk. You can correct for overfit. 90%, 5% confidence intervals and inference are not a good not a very strong decision analytic concept, but there's some limited cases where you might want to use them, and there's some very simple techniques available for calculating the 95% confidence interval for net benefit. People often talk about predictive versus prognostic. I've been saying the predictive framework is, what's going to happen to you. The prognostic framework is what's going to happen to you, and the predictive framework is more, are you going to respond to this particular drug? Very simple extension. This is the sort of the net benefit is always income minus expenditure times the exchange rate. So if you're just trying to predict whether somebody has something or not, the income is the true positive, the expenditure is the false positive, and then the exchange rate is the threshold, the odds at the threshold probability. In the case of you're trying to, in a prediction setting, the results of a randomized trial, for example, and is the benefit for the individual patient worth it, then the income is how many events you're avoiding, the expenditure is how many patients you have to treat, and the exchange rate is the minimum clinically important difference. This is now a little bit old. Yeah, I think I must have done this in about August or September. The decision curve analysis is now very, very widely used technique. This is if you go into PubMed and you type decision curve analysis in quotes. And you can see in 2021, there were 1,000 papers that even had this in the abstract. Right. So, God knows how many were using it, actually used the decision curve, but didn't use those words in the abstract. And you can see by, August or September of this year, there have been many papers with decision curve analysis cited in the abstract or the title as in the whole of 2021. It's been recommended in the Annals of Internal Medicine, in JAMA, Journal of Clinical Oncology, as our own paper in the British Medical Journal. So to sum up, our traditional accuracy metrics do not tell us the most basic thing about a model, which is whether it's a clinical value. And they're just simply not fit for purpose. Decision curve analysis does do that. Unlike a more traditional decision analysis, given the audience haven't talked much about the limitations of traditional decision analysis, but you don't really need much additional data. All you need is this idea of the reasonable range of threshold probabilities. It's extremely widely used. It's recommended in numerous editorials and guidelines. And there's very easy to use software, decision curve analysis. We're just about to update the website, but it'll be better next year, but it's still pretty good. Decision curve analysis, it has links to papers. There's the software you can download. There's data sets that you can use. And then there's an extensive tutorial. So it will tell you like, okay, now type in this code and here's the decision curve. Now, what you can see here is blah, 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 but which is wrong. So what you really need to do instead is type in this code and here's what you get, and so on and so forth. And then the traditional, just brief notes of thanks. Lots of statisticians have worked on this. Definitely want to shout out Ewout Steyerberg and Ben Balcalster, who are very well known prediction modeling experts from the continent who've done a lot of work, especially the influence of calibration on decision curves. Dan Soberg wrote a lot of the software. Stuart Baker from the NCI, he has his own version of decision curve analysis that he calls relative utility, but he did a lot of the underlying math supporting both techniques. So that's the end of my talk. I'll be very happy to take questions. I think that was a clap. I didn't hear anything, but I saw some hands moving, so we'll take it, right?
That's fine. I was trying to use a different mic, but yeah, I'll use this mic.
Oh, okay, that's fine.
Any questions from the room? Of course, anybody at home or anybody on their phones in the room, put your questions in the chat. But anything from the room? Any responses, even if it's just comments or queries? Slightly exhausted is the comment from the room. One question I have, because I've been thinking about this since I last saw your talk a while ago, and I've been wondering that obviously this is in the clinical space where we have, do this test, do whatever. Has anybody tried to extend this to something kind of epidemiological, or basically thinking about, the whole pandemic situation? Is there any way this could be applied to something like non-pharmaceutical interventions? If there's some, as you say, you can boil it down to the income expenditure expectation thing, or, false positives, false negatives. Could it be extended to those kind of concepts, or do you need to be able to measure individuals?
So I'm not quite sure I understand the question. I mean, what can you give me the scenario? What are you trying to evaluate in what scenario?
Let's say, for example, there was a big whole issue of non-pharmaceutical interventions when it comes to the COVID situation. Did lockdowns work? Did lockdowns not work? These kinds of questions. Right. And something, could we evaluate the cost of doing this and the expected benefit of doing them?
Oh, I see. Yeah, I think in traditional decision analysis, absolutely, right? Because, you put in your utilities and your expected probabilities and you solve the decision tree. Whether that can be fitted into a more simplistic net benefit framework, I don't know, right? I would be, to say, well, what's what threshold of what risk of prostate cancer would you have a biopsy? That's something that urologists deal with every day of their lives. Whereas, what risk of COVID would you do a lockdown? I think you're going to go and need to do some other work to get there. So, some of the it's sort of interesting because my original paper is the most cited paper in the Journal of Medical Decision Making. And, I thought I'd be sort of welcomed with open arms in that community because I'm like, wow, I brought medical decision theory to the masses kind of thing. And a lot of them are like, oh, no, you're just watering it down. And, you're not a real decision analyst. And, we like the more complicated models. And in some sense, they're right? I mean, this is all this is a simplified way of doing decision analysis. And you'd be better off most of the time doing a full decision analysis. It's just, they're very difficult to do and, take years and years and years. Did that answer your question? There's some questions in the chat. I'm sorry, go on.
I think it's something like, it's really complicated. I don't want to deal with it. Kind of, it's tough to translate. A lot of work needs to go into really inform the numbers.
What I'm saying is that this is a simplified way of doing decision analysis, in which, I mean, the beauty of net benefit is you have these four parameters. I mean, if I might go back to sort of sharing my screen again while we're talking. Oops, yeah. If I go to the window, I guess I can do that. You can see my screen again. I mean, it might not look the most beautiful, but you can. Here we go. So yeah, you've got these four, if this is biopsy or no biopsy for prostate cancer, for example. These parameters are utility is really difficult. Okay, what is the harm of not biopsying someone with prostate cancer? Then you have to know what's the probability it's going to progress, and if it progresses, is that a problem? Because you're going to require, what's the chance that it becomes incurable? And then if you give a biopsy to someone who doesn't have disease, how much pain does it cost? And how many days do you have to take off work with or without an infection? So you have these four incredibly difficult to specify utilities, and what we're saying is that with net benefit theory, you can convert them into one parameter instead of four difficult to specify parameters, one parameter that everyone gets and everyone has to use every day. You're not always going to be able to do that, right? If you can, then it's an amazing shortcut. If you can't, then you're going to have to go and work out do the hard work to work out what those utilities should be.
Diego?
Because to me, the fundamental difference in those scenarios is that for the prostate cancer, it's essentially an individual decision. COVID is an infectious disease, and so it's about spread to others. So I think the whole analysis has to factor in a complicated population perspective. But I think the population...
Can I just answer to that? Because
you about screening for prostate cancer, and I think it would probably just be handled by the difference in the prevalence. But then that drives, if you have the same threshold, you're doing massive unnecessary tests because of the prevalence. So I guess my question is, would this apply to a screening situation with appropriate adjustment to the prevalence?
Yeah, so a couple of comments there is you can use decision analysis on population-based strategies, right? So one of the ideas that's come up is maybe instead of giving every woman a mammogram, we plug their numbers into the Gale model, and we only give you a mammogram if you're above a certain risk on the Gale model. And let's look at a small number of different possible cut points, and you could see whether the net benefit of using the Gale model led to better mammography outcomes in terms of true and false positives. People who got mammography unnecessarily compared to those who got mammography and had breast cancer found. So you absolutely can use net benefit in to evaluate interventions at the population level. You also had a question about, we could sort of dive into PSA screening a bit. When I gave this talk in Copenhagen, there was one sort of PSA screening skeptic who kept on saying, this is all irrelevant because we shouldn't be doing PSA screening. And I'm like, this is an example for a statistics talk. So, whatever your feelings about PSA screening, this is just a hypothetical. None of these data are real, by the way. They're just sort of hypothetical data. But I didn't quite understand your point about PSA screening. You said something about prevalence.
So, two things drive it. One is the utilities of misdiagnosis. But if you're in a clinical setting, which is how I interpreted your scenario, somebody's coming with symptoms, you really don't want to risk missing a cancer if it's there. In the population, you're going to be swamped by false negatives. And so you generally need very different thresholds of suspicion.
Oh, yeah, right. Yeah. So that's exactly what you can do is, if you're looking at the prevalence will be far different in the population. And I can imagine. So we actually did a decision curve for PSA screening, but remember what we're evaluating is a prediction model, a diagnostic test, right? That's what we're evaluating. So what we did was we evaluated, should your decision to get a PSA depend on your prior PSA? So you've already got, your PSA, should you carry on getting a PSA testing or not, or should you just stop, right? So that's what we're evaluating. And we obviously, the prevalence of cancer, we used actually population data from Sweden where they don't have screening. And then the threshold probabilities were very different, right? So the prevalence is different, but we could still run a decision curve. But remember, we're not evaluating screening. What we're evaluating is a prediction model for the decision whether to screen or not. Let's just take some questions in the chat. So we've got urologists don't use a single PSA to make the decision to biopsy. They use the rate of rise over time. So I'm actually the guy that disproved that. If you look up PSA velocity in Vickers, the rise in time is actually not a value. But that's just a side point. That would be it. Remember, we're not again, it's just a hypothetical example, but remember what we're using decision curve analysis to evaluate, which is, models or tests. So if you came along and said, well, actually, what you should do is in your model, it shouldn't just be what your PSA is or your age or whatever, it should be your PSA velocity. And that's how we should make the decision to biopsy. Then, let's evaluate that. And a good way to evaluate that is in net benefit. So it would be good to know what extent an increase in unnecessary investigations is worth an increase in recall. So I'm not 100% sure I know what you mean by an increase in recall. So if that's Emma Briggs, if you could just type that in to the chat, then I can answer that. Someone asked about how does model miscalibration affect net benefit? So I think, whoops, we can go back and I can actually show you that. This is mainly work from Ben Van Kalster. So if I'm going to share my screen. So let's see what we have here. This is, oh yeah, here we go. Oops. Here. So I will get there soon. Decision curves show. Oh yeah, here we go. Miscalibration can be detected by a decision curve. So this is let's look at this calibration plot. We're over predicting risk, right? So we're predicting that they have a 50 or 60% risk, and then we have a 20 or 30% risk. Let's show how that cashes out in a decision curve. Well, let's look at this green. So the orange line is the well-calibrated model. The green line is this one that where we're over predicting risk. So why does this make sense? Okay, we're over look at someone with a threshold probability of 60%. They're saying, I'm not going to do this unless I'm really sure I've got the disease. And we're saying, yeah, you've got this disease, your predicted risk is 60%, but it's actually not, it's way lower, right? So for those individuals, their net benefit is actually lower than doing nothing, right? So if you actually see a decision curve where the net benefit of your model goes below the net benefit of doing nothing, you know that you're over predicting risk. What about here? This is when you're under predicting risk. You're like, here, 10% risk, and it's actually a 50% risk. Well, this is, in this particular case, this is the perfect calibration, is the orange line. The green line is the one for the miscalibrated model. And you can, if you come back here, you can see, well, there's somebody saying, I'm really, really worried, doc. What's my risk? And I'm like, it's only a couple of percent. And yet they actually have a high risk. So those people who are very worried about disease, who would get a biopsy even if it was a low threshold probability, then the model has a lower net benefit than treating everybody. So decision making is very sensitive to calibration. And so decision curves are very sensitive to miscalibration. And the exact way that they're sensitive to miscalibration is entirely intuitive. So that was the answer to that one.
Okay, so I'm thinking, Andrew, given the time and everything like that, might cut it there, and that's been fascinating. So one last round of applause, I suppose, for Andrew. One final question for you, Andrew, is about someone asking about the slides and availability and that kind of stuff. The website, is that where we redirect them?
Yeah, go to the website. As I said, we're updating the website over the next few months. We've got new code for Python and so on. So it's a good idea. We'll put some slides on the website too.
Perfect. Thanks very much. Okay, well, in that case, thank you everybody for coming today. Everybody at home. 3 great speakers. We had Maria, we had Deborah, and of course we had Andrew. I think it was a nice into the year, and certainly a bit of a tour de force as well. A lot of heavy stuff, especially towards the end there. So almost a round of applause to everybody for staying with us as well. And we'll see you all hopefully in the new year at the next event. Thanks to all the speakers, and thanks everyone back home.